Hello, I'm Bob Falcone, CEO of the Columbus Medical Association and its affiliates. Today, I'm joined by Dr. Andrew Thomas. Dr. Thomas is an associate professor of medicine at the Ohio State Wexner Medical Center. He is the chief clinical officer at Ohio State and is the Zone 2 lead for our pandemic response in Ohio. I've also got Joe Gastaldo. Joe is the assistant director of infectious disease at Ohio Health. He has been Ohio Health's lead on the COVID response for our zone. And then finally, I'm joined by Dr. John Weigand. John is the chief medical officer for the National Church Residencies. He is also the state lead for the quick response provided to nursing homes for a variety of things. And we can talk more about that as we go along. So let me just start by saying 18 months after we started doing this, giving these little updates, we're still doing them. And that's a bit disheartening. So Andy, let's start with you. Where are we? Where are we today with COVID in our hospitals in our region?
Well, I'll step back for a second, even just talk about where we are with cases, Bob. Back in our worst days back in December of last year, we were hitting 8, 9, 10,000 cases per day, back at a time when really no one effectively was vaccinated in the state of Ohio. We got down to pretty low case numbers across the state, down into the couple hundred a day, 300 a day in early July of this year. And really, I think everybody felt pretty confident as we headed towards the fall. And then really probably the last week of July, certainly heading into the first week of August, starting to see a rise in cases to the point where now we've been over 3,000 cases per day on average over the last 7 to 10 days. With some pretty high numbers, especially when you think about a case rate with about 60% of the over age 18 population vaccinated. Really, certainly those that are vaccinated have some risk of a breakthrough case, but we're really looking at a minority of the adult population that's unvaccinated. We're now seeing case rates, if you essentially on a per denominator basis, really of 8 or 9,000 cases on that same unvaccinated denominator. So it's a little surprising that it's come on this quickly. K through 12 schools are just starting in the state of Ohio last week and this week, and I think some of the choices being made by school districts to not have masking required in their schools can only potentially put some gasoline on the fire of these case numbers. In terms of hospitalizations, what we've seen all along with this is hospitalizations tend to start creeping up about 2 weeks, 10 days to 14 days after the case numbers start to creep up. And that's really what we've seen over the last few weeks, both statewide as well as here in Zone 2. We've seen significant increases over the past month, and really even just in the past 2 to 4 weeks. Today we're at 557 total hospitalized patients in Zone 2. We've crossed to 400 patients today in Region 4 that are hospitalized, and we were down for the zone in the 60 to 70 range, and now we're up over 500. So it's amazing how quickly this has changed in the course of a month. Actually, if you look at the rate of change over every 7-day period for the last 9 days, we've had a 120 patient jump in census. So, if you fast forward that for the next, say, 3 weeks, if we are, say, at 900 to 1,000 patients in the hospital, that starts to look like where we were in December, when our worst day, we had just over 1,200 patients in the zone in the hospital with active COVID. So I think it's a difficult phenomenon. Now, the good news is that today's numbers were relatively stable compared to yesterday. The ramp up has happened so quickly that I think discharges now, we think about a 5 to 7 day length of stay for those patients that don't end up on a ventilator. Hopefully we'll see discharges now start to rise and we'll kind of get at a bit of a steady state and maybe plateau. But when you look at what's gone on in the southern part of the United States, it's certainly probably we have a few more weeks of this with potential increases and higher numbers of folks being admitted to the hospital. So I appreciate you doing this today because I think it's good to get this message out.
Thanks, Andy. So from our call today, and we have calls almost every day as a region on COVID led by Dr. Thomas and others. On our call today, it was clear to me that we are full and we are coping. We're not sailing, we're coping. And it's not unusual for our hospitals to be full this time of year. I mean, it's just not. But what's unusual is that COVID is taking up all the excess capacity. Am I confused about that, or is that where we are?
Not at all. If you would look back a month ago, it was about 1 in every 30 or 1 in every 40 patients that were in the hospital in the zone were there because they had COVID. Now it's 1 in 10. If you look in our ICUs, it's more like 1 in 5 or 1 in 6 patients, and on the ventilator about the same. So it's starting to eat into our capacity. And I think unlike back in November, December, and January, when some of our routine business was a little bit lower in volume, we had staff that were tired, but they were still engaged. All hospitals across the zone are reporting issues with staffing. People that frankly have worked so much overtime, they're burned out and can't work more overtime. Some staff have retired or left the healthcare industry overall. And I think people are anxious that we just don't have that elasticity in our staffing models. So we're actually talking about some staffing standards that would potentially be what are called crisis standards of care to try and spread our staff more wisely across a larger number of patients. But that's going to be maybe a different patient experience and certainly a different staff experience than we usually would have, asking people that aren't bedside staff to maybe go in and help at the bedside. These are things that we were hoping to never have to consider doing again. But we're also looking at other things about how we use ventilators, how we use ECMO, and potential what we call allocation of scarce medical resource guidelines that say you've been on this therapy for so long, there's other people that need it. We only have so much of it. And we might need to look at making changes in how we allocate those therapies.
All very important, but also they all make me nervous. Joe, let's talk about virus. If you listen to the news, it's all Delta variant all the time. Give us a quick primer on the virus and the Delta variant and what it is or is not doing to us.
Yeah, so once a week, the CDC actually sends information out giving you the percentage of the circulating strain that is the Delta variant. And as of last Friday, 98.9% of all the randomly checked swabs in the Midwest were the Delta variant. There is no hospital lab that routinely can do genetic sequencing. So it is safe to say that in our community in Central Ohio, if somebody has COVID, it is with the Delta variant. So here's what we know about the Delta variant. It is more transmissible to about 60 to 70% compared to the Alpha variant, which was the variant we saw this past winter, which is about 50% more transmissible or more contagious compared to the original Wuhan strain. So we are dealing with a super spreader variant. And it is true that if you are vaccinated, you are much less likely to get infection compared to somebody who is not vaccinated. However, we are now learning that people who get vaccinated, what really matters in preventing infection is your antibody level. And you need a higher antibody level to protect infection. I was vaccinated, for example, in December of 2020. After I was vaccinated, my antibody levels became very, very high. I also had great stimulation in a different part of your immune system, your T cells. And it's that T cell stimulation that really protects you from severe outcomes from COVID-19. But as time goes on, people do have a lowering in their antibody level. And when you have lowering in your antibody level, that's what makes people more prone to get infection. So, like I said before, I was vaccinated in December of 2020. My antibody levels, I'm sure, are lower. And I'm probably at a little higher risk of getting infection. Now, in somebody who is fully vaccinated many, many months out, if they do get infection, they're very likely to be either asymptomatic or have mild symptoms. But people who have been vaccinated many, many months out still have that wonderful layer of protection of what matters the most, and that's severe outcomes from COVID-19. So what we're going to be hearing more in the near future our guidance and guidelines for giving additional doses. Even though they are going to be the exact same vaccine, they are going to be reviewed as if they are a new vaccine. So what's happening now with Pfizer and Moderna, they have not yet submitted phase 3 trial information for additional doses. But when they do, the FDA and the CDC is planning on reviewing those the exact same way as a new vaccine through subcommittees within the FDA and the CDC to give guidance on giving additional doses for people. So again, for me, I want to get an additional dose because I want high antibody titers to protect me from getting infection. But nonetheless, at this point in time, I still have a wonderful layer of protection against severe outcomes. Another thing that's really important, Bob, for people to realize is clearly, if somebody is fully vaccinated, if they were fully vaccinated last month or even 10 months ago, they are much less likely to get infection compared to somebody who is not fully vaccinated.
And Bob, can I add on to Joe's comment there related to the vaccine? I think we hear this from pretty much all the hospitals across the zone. They're seeing 85 to 90% of the patients that are being admitted to the hospital this summer and going into the fall that are not fully vaccinated. So I know at Ohio State, since April 1st, we've had through mid-August that 495 unique patient admissions to the hospital with COVID. Of those, only 7 out of 495 had no other reason to be in the hospital and had no other reason for the vaccine to not be effective. Now, within that 495, about 15% were fully vaccinated, but those were cancer patients, they were organ transplant patients, or they were people that came into the hospital because they were pregnant and found to be positive for COVID. They were trauma patients. They were all sorts of other reasons to be in the hospital. But if you look at people there primarily or solely for their COVID, and people that should have had a normal immune system, it's 7 out of 495 or 1.4% of folks were fully vaccinated. I think Joe's exactly on the mark that you might have a chance for a breakthrough case. It's even far lower than if you were unvaccinated, but you have very little risk of severe complications requiring hospitalization, a ventilator, or God forbid, death if you're fully vaccinated.
Yeah, that's true at Ohio Health too. The vast majority of our patients in the hospital with COVID are unvaccinated individuals. But like Andy said too, people with weakened immune systems, I've known for many years as an infectious disease doctor, the vaccines don't work as well in them. So we are still giving them their first series. So for those people with weakened immune systems, them getting a third dose is not a booster. It's actually giving them still their primary series.
But the current recommendation, at least for Pfizer, is for a booster at about 8 months after your last vaccination.
Well, those recommendations officially are not out yet. The CDC and the FDA states that they are expecting to have that. But again, just to recapitulate, the indication for giving a booster and anybody else who's not immunocompromised, those phase 3 trial information has not yet been submitted to the FDA. It's going to be reviewed as if it is a brand new vaccine. And that process has not even happened yet. But the experts at the CDC and the FDA have announced that they will likely have that towards the end of September for an additional dose in people who have been vaccinated more than 8 months ago. They kind of tease us a little bit with a tentative plan. That's a tentative plan now. However, as an infectious disease doctor, I actually want to see the clinical trial supporting the use of a third dose for people who were vaccinated more than 8 months ago.
So the bottom line is we're still a couple months away from vaccinating people with a booster dose. Does that sound about right?
That is correct. The only official recommendation now for additional doses are for those who are immunocompromised, classified as moderately or severely immunocompromised.
And just so you get a sense of the scope, Bob, the state estimates that across the state of Ohio, that's 2 to 4% of those who've already been vaccinated. So like to Joe's point, this is not something yet that's been released for the entire population or like everybody over 50 or anything like that. This is really for that subset of folks that are organ transplant patients. They're currently on chemotherapy. Maybe they have CLL, so they're chronically immune compromised. They have, advanced HIV. They're on biological treatments or high dose steroids or other things that would make them, have their immune system not work so well.
Yeah, let's come back to vaccines in just a minute. John, as you know, many healthcare organizations and many other organizations are mandating vaccines for their employees. And we can come back to Ohio State and talk a little bit about what you're doing. I think it's pretty rational in Ohio Health. We can talk about what you're doing. But that's got a pretty serious impact in the nursing home industry, doesn't it?
Well, I would say it probably has a severe impact in any healthcare industry or any industry whatsoever. But certainly in nursing homes, we've seen staffing challenges, just like Dr. Thomas mentioned. Fatigue is at an all-time high. And, I think we had thought that, we had a respite over the course of the summer, and that's not the case. Moving into the fall, what's worrisome from my standpoint, and so what I'm currently doing, my most recent activity that's keeping me out of trouble is that I'm the chief medical officer for this group called the Regional Rapid Response Assistance Program, or R3AP, the RAP program, through the Department of Aging. And so we have access to, Department of Health data, the dashboard that looks at outbreaks in nursing homes and assisted living facilities. And what has been encouraging to this point is the cases that come out have primarily been in staff members who, about 50%, I would say, of the staff that we're calling, the facilities that we call the staff have an acceptance rate for vaccination of about 50%. The residents almost week over week exceed 90%. And so what we've seen is that, despite having these outbreaks, the vaccines have been terrific at protecting the most vulnerable. And I worry about employees getting this and having outcomes that I wouldn't want to see in employees if I were hiring them. The residents, though, have for the most part been protected until the last several weeks. And I think the Delta variant is starting to, we originally said, COVID doesn't play by the typical rules. It can be spread amongst asymptomatic individuals. And so we talked about how initially it didn't play by the rules. The Delta variant isn't playing by the same rules that the original COVID virus played by. And so we've had to pivot a fair amount. And so my concern is all the hospital data that we've talked about to this point really hasn't reflected the elderly. And now I'm concerned that we're going to start seeing perhaps an upswing in some of the elderly. Now we've been able to remediate that using, a variety of different treatments like monoclonal antibodies. And we've seen that over the last week, I would say.
Yeah, John, if you look at least at Ohio State of our average age of individuals being admitted, if you look at those over age 80, back in November, December, and January, we were running about 12 to 15% of our total COVID admissions were in that over age 80 group. It's now down in the 3 to 5% range. So we've kind of truncated off, to your point, the older age population by vaccinating them pretty effectively over the wintertime. I think you're certainly right. It would be a concern if we were having large groups of those individuals becoming symptomatically positive to the point where they need to be admitted to the hospital. That would be a game changer from the vaccination perspective.
And John,
those over 65, it's well over 85, about 85% are vaccinated for individuals over 65. That's been great response.
And John, that does make sense too with what I was talking about earlier before. So most people living in extended care facilities were vaccinated earlier on, December, January. And that would make sense where we need to, once we get the final recommendations for additional doses for people who've been vaccinated more than 8 months ago, those would be people that we really want to prioritize to give that third dose, really to get their antibody titers up high. And remember, the antibody titers, having a high antibody titer is what prevents and helps really mitigate infection. So that would be, I'm anxiously waiting for that guidance to come out once we get there in September.
So it sounds to me like one of our important takeaways so far this morning is people need to be vaccinated. And if a booster becomes available, then it's probably a good idea. But the first line of defense is still people need to be vaccinated.
Yeah, absolutely. In our country, in the infectious disease world, a lot of people are kind of have mixed signals about giving additional doses to people when other parts of the world haven't even started giving their vaccines yet. And I kind of agree too with those in public health and the government. So we can do both at the same time. our country is very blessed. We have 3 safe and effective vaccines. And I do think it's reasonable to, again, really get vaccines out there to the rest of the world, but also to protect ourselves the best we can. And we really want to get infection down as low as possible in our community and in the whole world. You know, if infections is not made lower, we are going to eventually get through the whole Greek alphabet with more variants.
Yeah, let's come back to that in just a minute. Andy, Ohio State announced what I thought was a very rational approach to vaccination, and basically it's mandated it for everyone with 3 exemptions. As I understand it, it's deep personal conviction, it's religious, or it's healthcare, it's medical. And if you are one of those people who gets an exemption, you got to get tested every week. Is that about right?
That's exactly right, Bob. You know, we had some limitations based on state law that we needed to wait until at least one of the vaccines was fully FDA approved. We're now at that state as of Monday. Certainly the EUA still applies to the Pfizer vaccine for those aged 12 through 15, but at the university, that really doesn't impact us like it would maybe a K through 12 school. But so for pretty much every member of our university community now, there is an FDA fully approved vaccine. So the expectation is that individuals will get their first dose by October 15th. There are exceptions, and we're actually rolling out next week a new portal where people will both report their vaccine status as well as request exemptions. And then we're working through the process. We already have obviously a large testing operation that we've done with weekly testing for our students. This year, we're only testing, we did pre-arrival and arrival testing for all students, but then the weekly testing is only going to be on vaccinated students. And so we'll have ample capacity to add in those faculty and staff that need to get the weekly testing if they have an exemption through that process. Then they also, I guess, could go to CVS or wherever if they wanted to get their testing done too. But yeah, it is. I think I was very proud that the university took that step. I think it's a great signal to other employers in the community, certainly to other educational institutions in the state, that we think the science is there. And we think this is the best way to, in our community where we're both an employer, an educational institution, and really a big landlord, that we love to have people living in communal settings, sharing bathrooms, other things, that this is the safest way to keep our campus safe and healthy.
Yeah, and I think that from a practical standpoint, that will have some impact on staffing. And John, I think in your area, you're going to see a serious impact in staffing. Biden has said that he's just not going to continue to support nursing home expenses through the federal government if they are not vaccinated. Good medicine, but it sounds like that's going to be pretty difficult.
Well, going back to something that Andy just mentioned about, testing unvaccinated individuals, that's what we've been doing in nursing homes for the whole pandemic. And in fact, since last winter, unvaccinated individuals have been being tested twice weekly. And that's been, one of the ways that we've been able to keep our eyes on what's going on within these facilities. That announcement from Washington, D.C., took a little bit of the air out of our sails, so to speak, and really did cause a buzz, not only because of just the general announcement about healthcare providers, but singling out nursing home facilities and linking that to financial remuneration seem pretty draconian. And there's been a fair amount of conversation in our circles about that. What I think the reality of that is that there's a process, and I guess making announcements through pressers maybe a somewhat dangerous way of going about doing it. But, there are a lot of steps that have to occur from the president making that decision, which may seem like a very logical decision, but, it's going to have to go through HHS and through, the CMS. And so there's got to be a lot of policy put behind those words. And as we've already talked about with like the FDA, that's not something that happens really quickly. So that may come to fruition. If it does, it's going to devastate an industry that's already been damaged and is going through a post-traumatic experience with the new Delta variant. But this is going to become, unfortunately, I think, a norm for us, and we could be probably talking about this next year. It'll be something different, and it's going to have to pivot, and we're going to have to try to be as nimble and flexible as possible. And I do have concern about all our healthcare providers, and not only nursing homes, but the acute care setting.
One of the things along those lines, John, that I think about, Bob, with this vaccine requirement is, for individuals that are unvaccinated, with this rise in cases in the community, especially with everybody under age 12 can't get vaccinated and kids are going back to school, are many of our staff, whether they're nurses, respiratory therapists, doctors, whatever it is, nurses, assistants, they're parents. So if their kid comes home with COVID and they're not vaccinated, they're going to need to quarantine for at least 7 days, probably 10 days. And that's going to we already have impact on our staffing. Trust me, that's going to make things tighter if we have 10% or 20% of our staff out in quarantine, much less sick in isolation. But if you're vaccinated, you don't need to quarantine. Now, they do want you to get tested within 3 to 5 days of your exposure if you're vaccinated, but that's going to be a game changer for smaller hospitals and larger hospitals to be able to weather this new storm in our communities.
And when you think about it, John made a very good point, and that is that there has to be some process. In my experience, whenever the federal government and the concept of nimbleness and flexibility come together, they are antithetical. So the more of this we can form and develop on our own, probably the better off we will be as a community. I'd like to come back to Joe. You had just started to touch base on something I think is very important. Early on, we were all herd immunity this and herd immunity that, but when you really think about it, the herd is the world in our current environment. It's not Columbus, it's not Ohio, it's not the United States, it's the world. So we are still hell and gone from herd immunity. Africa, what, 2% are vaccinated?
Yeah, but Bob, and that's very concerning too. So everybody knows that the Delta variant was first identified in India, and we will likely get through the whole Greek alphabet when it comes to the naming of the variants. And my concern moving forward is that very likely we are going to have more variants, and the nightmare scenario is that there is a variant that evades the vaccines that we have. And again, we need to respect the variants and study the variants and plan accordingly. What I see happening now internationally is very similar to what they do for influenza. So they have, to keep it simple, throughout the world, they have various labs doing genetic sequencing on strains of influenza. And they use that information to kind of predict what's going to be the predominant circulating strain to make our flu shot. So I see that same type of mechanism being built for SARS coronavirus too, when it comes to doing genetic sequencing throughout the world, sharing that information from country to country, studying that in the lab, doing antibody studies, this, that, the other. So if there is a more sinister variant that is identified that tentatively may be evading our vaccines, we would be prepared to that with coming up with a novel mRNA vaccine that would cover a specific type of variant. So again, this is very forward thinking, and I don't really think anybody can predict what's going to be happen. That is the worst case scenario, but we need to be prepared for that because this virus is unpredictable.
And when you think about it, the flu is, fortunately for us, kind of a yearly cycle, and we update before the season starts, and we get people the appropriate vaccine or the vaccine that we think is most appropriate for what we feel is coming to us. COVID seems to be a quarterly cycle. Dramatically shortened. We go up, we go down, we go up, we go down. I think that process is going to be harder, but I agree with you. I think we're going to see maybe yearly vaccinations.
Yeah. I mean, variant development that happens anywhere can affect us. It's going to affect us. And, if the Delta variant was first identified here, we would be in a much more dire situation than having it first be identified in India. By the time it hit our shores, we actually knew more about it.
So let's stick with you for a while and talk about the vaccines. I don't want to get into details and split hairs between the vaccines, but the vaccines in general, the ones that have been approved, at least for EUA in the United States, and the one that's been approved for regular use. They are safe and effective. They won't magnetize you. They won't make you sterile. And they will probably have very, very few side effects. But if I'm listening to you and asking you what are those side effects, what should I be concerned about if I get the vaccine?
Yeah, so the most common side effect actually being reported is pain and discomfort at the injection site, followed by fatigue, muscle pain, low-grade fever, typically what I call mild flu symptoms. And again, you cannot get influenza or COVID from these vaccines, but that reactogenicity is a reflection of your immune system being built up to give protection against COVID-19. To date in our country, we have given over 360 million doses of these vaccines. And unlike any other vaccine in the whole history of vaccines, with the COVID-19 vaccines, the FDA and the CDC set up many mechanisms to ascertain for any safety signals or adverse reactions from the vaccines. And when it comes to the Pfizer vaccine, the one that's FDA approved, we have given over 200 million doses of the vaccine. So what anybody could do for Pfizer now, you could actually Google the package insert for the Pfizer vaccine and look at the vaccine side effects reported with that vaccine. So again, these vaccines, they are safe and effective. Because of the mechanisms that are in place, we've identified 3 potentially adverse reactions that are very rare, very uncommon. And when you look at the risk-benefit ratio of being vaccinated compared to not being vaccinated, the benefit far outweighs being vaccinated. You know, there are people out there, and I talk with a lot of people who are more fearful of the vaccine than actually getting COVID. And that's really a reverse mindset. If you have to pick to get immunity from either being vaccinated or getting COVID, I would want to be vaccinated. It's a much riskier scenario to get COVID than to be vaccinated.
Yeah, the best example, Joe, that I've used with patients that are really concerned about the vaccines, you know, the mRNA vaccines have a very, very low risk, but a true risk of causing myocarditis with the vaccine. The published rate is 1 in 50,000. Based on some published studies in terms of getting myocarditis with the virus, it's more like 1 in 50. It's probably actually even higher than that. It's probably more like 1 in 20, 1 in 25. It's a 1,000-fold difference in risk. And not to mention all the other risks that come along with getting the virus of brain fog, fatigue, missing 2 weeks of work, all those other things. That 1 in 50,000 risk of a mild myocarditis that frankly, nearly all patients recover from just fine compared to a 1 in 50 risk of that, plus all the other risks you run, plus spreading it to your friends, family, your church, whatever it is. I think, Joe, you're right on the mark that it's and I do think sometimes people just aren't putting these things in context. 1 in 50,000 sounds kind of risky, right? If you don't realize that the risk of the virus is 1,000-fold higher. Same thing with Guillain-Barré from the J&J vaccine. There have been, 100 plus cases of Guillain-Barré out of 12, 13 million doses of the J&J vaccine that have been given. If you listen to, the NPR story on it at the end, the last sentence is, and by the way, the rate of developing Guillain-Barré was no different in the J&J vaccinated population than it is in the general population. So yeah, there are 100 plus cases of this horrible neurologic condition. We've all seen it. Guillain-Barré is not a great condition to have, but that's no different than the same rate of people when they have a bronchitis from something else. It's out of context. These things sound really scary, but in the context of the virus itself, vaccination is far safer.
Yeah, but I think one of the challenges, though, is that we're fighting against a social media machine that almost everybody's using it. It feeds off of drama. And, the reality is people want to get likes and they want to be viewed. And so they come out with this information and, quite frankly, false information to get more views. And that becomes the narrative that, quite honestly, the white coats are fighting against. And it's just tragic in my mind, because I think it's influencing some of the individuals who have been hesitant to this point. And just listening to some of the the tales and falsehoods that are out there about, how the vaccines are causing people to be sterile and aborting babies and everything. People are being, Dr. Thomas, you can tell me, are there deliveries being done at Ohio State University? We all know the answer is yes. But, putting those things together, just logic together is not something that we're doing a good job messaging.
Yeah, John, I'm only one person, but what I've learned from talking to probably hundreds of people over the last year is, when we talk to people who have not yet been vaccinated, when I talk to them individually, I always come off the press and say, I'm talking to you from a vantage point of caring, respect, and understanding. I want to talk with you. And it boils down to two people. It's a person who has a matter that they need answered from a trusted, reliable source. And a lot of people don't have access to that. And the second group of people are people who believe something, and they believe something that's been handed to them that there's no scientific validity to. So typically what I tell people is, hey, let's talk. Come to my office. Let's shut the door. Let's have a cup of coffee. This is a non-judgment zone. I've been at this for a while. And if there's something about the vaccine that that I don't know, teach me, because I want to learn about it. Right. And, there are people who do have concerns that they can't find reliable answers to. And there are people who believe things that are not valid. And we have to respect those people and really talk with them from a vantage point of caring and understanding, and not talk at them or make them feel marginalized.
Yeah, Joe, I agree with you 100%. The mantra I've been using with our teams is, you meet the person where they're at. And John, to your point, there is a small number of people that are spreading disinformation and misinformation. And frankly, it's just disrespectful to our communities. It's really sad that people feel the need to do that. But the vast majority of people, I think, have, well, like I said, legitimate concerns that they just don't understand the context of the data that they have. They're trying to do their best to read. Obviously, it's great that the CDC and FDA are being very transparent about all these things. But at the same time, without proper context, and the term that it's an old Will Rogers aphorism that, everybody's ignorant just about different things. I was actually asked to talk to one of my wife's coworkers' husbands the other day on the phone about getting vaccinated. And I said, sir, I don't know what you do for a living, but I can tell you, I wouldn't know how to put shingles on my house. I wouldn't know how to fix my car. I wouldn't know how to do a lot of things, but I happen to know about this. And I think it really kind of got through to him that I was answering his questions. And frankly, the other thing I do get questions about is, I had COVID in March. Why do I need vaccinated? And I don't know, Joe, if you want to touch
yeah,
on
a couple things on that. So this is a very common question I get. Yes, it is true. If you have COVID, you do have a degree of immunity for a period of time. That degree of immunity is quite variable from person to person. It's really based on severity of illness and your age. Older people don't have as robust immune response to vaccines, or from that you get from infections. And also too, your severity of illness is indicative of that. So the other thing too that people need to realize is, there's no way to measure somebody's immunity. Antibody tests are not recognized as markers of immunity. Antibody tests that are out there are all FDA approved under emergency use authorization. They all perform differently. We don't know what antibody number means somebody has immunity. I can tell you anecdotally, I know of 3 patients who have had antibody levels done at 3 different labs, and they get 3 different results. So there is not a way to measure immunity for people. In addition to that, there is beginning to be more publications comparing breakthrough infections in people who have had COVID compared to people who have been vaccinated. Everything related to COVID is full of nuances. And then most importantly, we know that it is extremely safe to get a vaccine if you have had COVID. There is absolutely no increased risk of danger at all, from being vaccinated. Now, one thing we have learned is that if you have had COVID and you get vaccinated, that immune response, the reactogenicity, is felt more. People have a pain at the injection site. They'll have a fever. They'll have a headache. But those symptoms are all resolved within a few days.
If I could make one quick comment
Please.
about something that Dr. Thomas had said. one of the best practices that I've seen in trying to break through and meeting people where they're at is a number of nursing homes and assisted livings have isolated a 10-minute period at the beginning of the day where they sit down with their staff and say, where are you? What are the things that are concerning you today? Kind of doing the huddle, if you will. And they can pick off a lot of those situations and the misinformation or just concerns that they have. And then if they do have questions that the facility can't answer, then they reach out and they try to get the answer. And so, that's a strategy that I've seen kind of bubble up from, the front lines that I think has helped demystify some of the vaccination and encouraged. And we've actually done better, I would say, in the last 2 or 3 months in vaccinations and nursing homes and other congregate settings because of those types of innovations, which, I hate to say innovations are, talking to people. But
another thing, John, I'm really asking people to do too is really get in this mentality of FOMO, fear of missing out. It is not a HIPAA violation to ask somebody if they have been vaccinated. I ask leaders, physicians, nurses, people in the community to share their experience of being vaccinated. What was the experience like for you? What does it mean for you? We really need to kind of create a buzz about being vaccinated. And I think a lot of people are fearful of having that conversation with people. But if you do it from a vantage point of respect, caring, and understanding, it comes off very well, but we need to celebrate that. I was vaccinated in December of 2020. It really meant a lot to me personally to be vaccinated as far as my safety and protection and my family. And we need to share those stories and celebrate that. And I wish we can kind of do a redo on that, but a lot of people are really afraid to talk about that with their friends or family or their communities.
Joe, I had a really unique experience a couple of weeks ago. Someone who's worked at Ohio State for almost as long as I have, pulled me aside on the way out of the hospital on a Wednesday evening. And she said, Dr. Thomas, I think it's great, everything that we're doing. I just want to tell you, I'm not vaccinated. And I've known the woman for over 2 decades. And she said, can you talk to me for a minute? I said, sure. And we talked through a couple of questions she had. She's like, oh, that's good. I'm just really scared. And I said, well, I'm actually off on Friday. How about I meet you on Friday over at the Arlington vaccination location? I'll go sit with you. I mean, she was literally like worried about having a reaction in the moment, right? And I said, I'll come sit with you. She goes, would you do that for me? And I said, of course. And I kind of came up with this concept. If everyone who's vaccinated just found one person that is not vaccinated, their church, their workplace, and their family, and their neighborhood, their child's friend's parent, whatever it is, if we all just could convince one other person to be vaccinated, this would be over. And maybe it's a matter of like we drive people to polling places, we drive people to church, we do Meals on Wheels. Maybe we just need to, if everyone just picked up and found one person they could drive to get vaccinated.
Those are all really good points. And I think that they are important for us to emphasize. And I think another important point is that social media has not been our friend. It has democratized science and medicine. And when everybody's an expert, nobody's an expert. So I really like your approach, Andy, of saying, I'm not an expert in everything, but I am an expert in this. And this is my best advice. And John and Joe, I like your approach of meeting the person where they are and having an honest conversation. Finally, Andy, I think that's going to be my ask from the time we spent together. We are preaching to the choir. It's time for the choir to go out and do some preaching.
Bob, in my opinion, we've done way too much preaching. And I think people, I've heard the analogy that usually when I hear somebody preaching a sermon, I fall asleep. That's not me. I usually am trying to pay attention to what's being told to me. But, I think it's we have to, the parishioners have to talk in the pews. And what I'm hearing everybody say is, we just got to talk to people, and we've got to encourage them and, demystify this, and it's going to take a community effort, and that doesn't mean all the doctors on the line. It's got to be people who have been vaccinated, who are in child groups, and in all those different social circles that people work through. And so the more we get that out, I think the better.
But I think Andy's point is very important. It almost has to be hands-on.
Yeah.
Pick somebody in your sphere of influence that is unvaccinated, speak with them. And if the problem is as simple, Andy, as you said, on the one person, I'm afraid, go with. I know that's an incredibly inefficient use of your time, but if everybody did something like that, the vaccinated would get all the vaccinated pretty quickly. So I think that first and foremost, we can agree that the vaccines are effective, they're safe, and they are our first line of defense. We can agree that getting vaccinated for those people who are skeptical is not that easy, and it's going to take a personal commitment from all the people watching today to get their buddies vaccinated, get their families, their friends, their coworkers vaccinated. And finally, I don't see this gone this year. I don't see this gone next year. And I suspect we'll be back here talking again. Any last thoughts?
Just thanks for doing these, Bob.
Thank you all. Thank you for your time.
Thank you.
Dr. Thomas, Dr. Gastaldo, Dr. Weigand, for the Columbus Medical Association. This is Bob Falcone.